Beep, 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 beep. Welcome to the court of the Edie Jester. Hello, and how are we all? Good day, Cobber. We're going down under. We're going down under to explore an article by the redoubtable Edie Wyatt, who was one of the first people to ever interview me in regards to this absolute nonsense we find ourselves embroiled, enwrapped, entrenched, and generally drowning in. Okay? So there's a really good article here that's come from Edie, which is about truth-telling. It's called Truth-Telling. Okay, and I think that's a very apt title. Buy me a coffee, send me a super thanks, like this, like it and share it, please. That's big. Like and share it, because that's really important. It gets the algorithm working for me. Truth-telling, interesting. The dark side of Queensland's gender clinics and affirmation care. So we're into the realm of care again here. Very much up for grabs at the moment because of what's happening in Britain and France and other countries moving forward and saying no to this. It's interesting to get a take from Edie, who of course works, lives, and her activism is centred in Australia. Last month in Cairns, the Royal Australian and New Zealand College of Psychiatrists, RANZCP, or RANZCP, held a Queensland branch conference at which there was a stark admission by a prominent Queensland psychiatrist to the lack of evidence for the controversial gender transitioning of children that is happening under the gender affirmation model of psychiatric care for children with gender dysphoria. I have had more to do with psychiatrists than I would have liked in my life. A genetic inheritance of insanity runs through my family in the form of Huntington's disease. It might be a surprise to many readers that I've been passed over by the insanity gene. In having tested negative for the gene that leads to Huntington's disease, I am labelled not affected by the medical specialists in the field of genetic disease. Like many labels invented by doctors, this one is inaccurate. After decades of dealing with the psychiatrists of the Queensland public hospital system, I'll let you in on a secret. Psychiatrists don't always tell the truth to patients. The truth is sometimes distressing, and psychiatrists are in the game of reducing distress. Many of my family have been given false diagnoses of mental illnesses to avoid upsetting them with the truth. The truth is that they were going insane, and there was nothing anyone could do to help them. Psychiatrists always told me the truth about what was happening to my family because I was not the patient, and it wasn't their job to lie to me. In my experience, if a psychiatrist is telling you the truth, you are probably not the patient. Prominent paediatric gender psychiatrist Dr. Stephen Stathis attended the recent North Queensland conference where he addressed his gender-critical colleagues with some truth-telling. Dr. Stathis is the Medical Director of Child and Youth Mental Health Services at Children's Health Queensland and was recently on Four Corners promoting the affirmation model of treatment for gender dysphoric children. Dr. Stathis established the Queensland Children's Gender Service in 2017. The gender affirmation model of treatment for gender dysphoria is based on the theory that people have an inherent gender identity, and that this gender identity is either congruent with sex or incongruent. Because there is no way to tell if gender incongruence will cause a person lifelong distress with their body, psychiatrists perform predictive testing for the severity of gender dysphoria in children in an attempt to detect a kind of true transgenderism. The concept we've heard of, this is me, the concept we've heard of is, of course, true trans, which is something that comes up quite often in discussion and something that is I think when you're on the pathway to understanding what all this is, I think that's the last vestige of it you let go. But there's such a thing. You go, actually, there's not. I have to admit there's not. This idea of true transgenderism. The tests revolve around the question of whether the cross-sex identification in the child is consistent, persistent, and insistent. That's an interesting use of words there. An interesting framing. Consistent, persistent, and insistent. Controversy has surrounded the practice of the affirmation model of treatment for gender dysphoria in Queensland, with recent claims that a Brisbane plastic surgeon is allegedly performing double mastectomies on girls as young as 13. Under Dr. Stathis, Queensland has embraced the medicalisation of gender nonconformity at higher levels than most other Australian states. with 922 patients being treated by Queensland Paediatric Gender Clinic in 2022. Gender-affirming treatments include puberty blockers to stop the development of adult sexual organs and secondary sex characteristics, as well as cross-sex hormones that allow the patient to imitate the secondary sex characteristics of the opposite sex. That's what, gender-affirming treatment is supposed to be about, isn't it? Yep. But let's not forget one very important factor about this idea of this surgery that is supposed to produce a facsimile of the other sex is that the failure rate in terms of being a sex change operation is 100%. They all fail because it's not something you can do. It's the strangest response to a mental health diagnosis since the idea that lobotomy could calm people down and that eugenics could make them better. I personally think it's in the same category. And if you don't think it's in the same category, perhaps we could at least agree it's chasing on the heels of the other two. Edie continues, one of the major assumptions of the affirmation model is that if gender dysphoria does persist into adulthood, puberty suppression offers a patient the best chance to pass as the opposite sex and integrate more seamlessly into society, and this will make the person essentially happier. Gender-affirming care for children is primarily cosmetic in aim. The mental benefits are purported to be gained by the way society and the person themselves reacts to the body of the transgender person. Very interesting point. The problem is, says Edie, that there is no evidence gender affirmation treatment in minors has better outcomes on the mental health of the patient long term than if the person was allowed to mature sexually with the ongoing assistance of psychological and social support. It is important to note that in taking a more watchful waiting approach, gender-critical psychiatrists do not assume that every person will stop identifying as transgender with puberty, just that the development of sexual organs will not hinder the mental health of the person and will almost always help them. Many adult trans-identifying individuals have fully developed and functioning sexual and reproductive organs. If gender has nothing to do with the type of genitals one has, why is allowing children's sexual organs to develop inconsistent with a trans identity? In his speech to the conference, Dr. Stathis indicated that his focus is on the difficult task of shoring up the predictive testing for gender dysphoria in children in an effort to catch only people with a kind of innate transgenderism. These individuals, it is assumed, will benefit from the halting of puberty. I couldn't disagree more. There is no benefit to any of it to anyone, least of all society. Before the gene was mapped for Huntington's disease in 1993, psychiatrists used to perform predictive testing on children at risk of the disease in an attempt to diagnose propensity for HD. Given the realities of gene inheritance, this was already a 50-50 guess. But they got it surprisingly wrong, surprisingly often. Predictive testing concluded incorrectly that my mother did not carry the defective gene. You will understand my skepticism in predictive testing for something that is far less evidentiary substantial than a genetic disease. As far as I can see, there is no evidence for such a thing as an innate transgenderism. There is no evidence for it at all. Stathis attempted to address what he called the elephants in the room, by which he appeared to mean gender-critical opposition to the affirmation model. One of the elephants Stathis mentioned was the explosion of gender dysphoria as a diagnosis in children. The increase in gender dysphoria testifies against the idea that transgenderism is a phenomenon manifesting naturally in the mind of children and suggests it is heavily subject to external and societal factors. Even though Dr. Stathis admitted that trans identification among children increased during COVID, he denied that it has become a type of social contagion amongst youth. How can you not see it? Stathis claimed that just as left-handedness increased with societal acceptance, so has gender dysphoria increased with the growing acceptance of trans-identified people. A truly stupid argument, says Edie. Dr. Stathis made two concessions in his talk to his gender-critical colleagues. One was that puberty blockers appear to affect bone density, and the other is that puberty blockers can no longer be considered a pause on puberty, as 95% of children who start on puberty blockers go on to take cross-sex hormones. This is a brilliant piece by Edie. It's deeply thought through, and I've just scratched the surface. It's a marvellous essay. And I will stop there because I think you're beginning to get the gist of what is occurring. And we're seeing Australia begin to understand that, looking to Europe and particularly to the UK, where we are essentially ceasing puberty blocker provision for all but the smallest number, which would be in a research framework, which I think may never happen. We're ceasing it, the blocking of puberty blockers, is that they are waking up to the fact that this whole thing has been a damned lie from the beginning. I saw a quote, actually, from 1973. I wish I'd saved it and I didn't, of a woman talking about keep these men out of our spaces. That was 1973. This whole thing has been a lie from the start, the whole damn thing. It's all about the production of facsimiles, the production of fake bodies that are able to hide in plain sight. That's what it's been about from the start. Now, it was also about attempting to alleviate something that the individual was going through. But if we look at John Hopkins, they stopped doing it almost immediately once they understood what was going on. That was way back in the 70s. So the situation as it stands at the moment is we've had a resurgence of something which has a likeness to eugenics and lobotomy, and as such is going to need to be stopped legislatively. I was horrified to discover that the children that were on puberty blockers are still doing so. They're still doing so. And that, from my perspective in the UK, you should stop it immediately for all of them. End of story. End of story. And that's it. That's the only answer. Is it's banned completely with immediate effect. And to supply it or to obtain it by illegal means should carry the same penalties as any other Class A drug, such as heroin. It should be illegal to sell it in this country. It should be illegal to provide it in this country. It must end, and it must end immediately. It's a very hard decision we have to make, because what we know is the vast majority of these children are same-sex attracted. And just to make it simplistic for you, that's 95%, it's probably say 90% same-sex attractive or ADHD. So my suggestion is that we hurt the ones that are on it now to save the ones that might be in the future. That's a horrible thing to say, and I'm not comfortable with it at all. But the truth is, I will not sacrifice one gay child or young person to appease the mental instability of another. It's that simple. Withdraw them totally. They have absolutely no purpose whatsoever beyond becoming a sort of break on precocious puberty, which is their original use. And I think by doing so, we begin to end this problem. Supply them in this country, and you receive that supply, we'll lock you up. It's that simple. Right? So we need a worldwide moratorium to make it even tighter. We need people to say that the supply of puberty blockers outside of a recognised medical, whatever it may be, only for precocious puberty. So what we need is the worldwide ban on puberty blockers, the same as we have on heroin. That will end the initial part of this. And then we have to deal with the social transition, which is, of course, far more dangerous, in that it begins the process which cements in the individual, particularly a child, the deluded beliefs under which they live. And that, I think, is even more dangerous. It's iatrogenic. Once you start that, it's almost inevitable, and the whole thing's going to happen. You go 12 months down the road after that, what's the kid going to do? Oh, no, actually, I'm not. I'm back to being a boy now, are you? Now, some will, very few. Because once you've committed to that in a social sphere and you're that young, it's going to take you by the neck and drag you forward. An immediate worldwide ban on the provision of puberty blockers. End of story. That's where we're going. Okay, that's me done for today. Thank you very much, Edie. I have put the link to the Spectator article in the Dubries. Please do go and read the rest of this excellent essay. I cannot recommend it highly enough. Thank you very much for listening. I'll see you later. Bye, peeps.